And the first session up is the PARP Revolution, how PARP inhibitors are changing the landscape of ovarian cancer treatment. I'm excited to introduce you tonight to Dr. Shaina Lee. Dr. Shaina Lee is a gynecologic oncologist at the Alan Blair Cancer Center in Regina, Saskatchewan. And tonight, Dr. Lee will share with us some of the latest information on PARP inhibitors and how they're changing the treatment landscape. Dr. Lee will be interviewed tonight by two members of Ovarian Cancer Canada's Patient Partners and Research Team, Peggy Pickett, who is a Teal sister from Niagara Falls, Ontario, and Patty Pitts, who is from Vancouver, BC. Patty lost two close friends to ovarian cancer in 2018 and has been a member of the Patient Partners and Research Team since its inception. So thank you to all of you for joining us this evening. And Dr. Lee, I will pass it over to you.
Hi, everyone. I'm Shaina Lee, and I'm a gynae oncologist from Regina, Saskatchewan. So during this session, we will try to spend most of the time discussing and doing a Q&A session. So I will keep my presentation quite short and simple, so that we can have as much time as possible for our discussion. So I will just share my screen. All right. Okay. Can you all see my screen?
Yeah, we can see it, Shaina.
Okay. So yeah, we will spend the next 10 minutes or so going over some background information on PARP inhibitor in ovarian cancer. So we will talk about what a PARP inhibitor is and who's eligible to take a PARP inhibitor in Canada at the moment, and what types of PARP inhibitors are available here, and what kind of clinical benefits have been shown in previous trials. So I've had several patients who ask me how a PARP inhibitor works and why it will work well for those with BRCA mutation. So I thought I would try to explain the mechanism action of PARP inhibitor. So our human DNA has two strands, and as the cells are dividing, as we live, there can be some errors that are made in DNA when they're dividing. So those errors may be error in one of the strands or breaks in both of the strands. And we intrinsically have several mechanisms that can repair those damages on DNA. And PARP, or a poly-ADP ribose polymerase, is one of the protein molecules that can repair when there is a defect in one of the DNA single strands. So if we use something like a PARP inhibitor and inhibit the action of PARP, then the cell cannot repair the single-stranded breaks, and those breaks will accumulate and will result in double-stranded breaks. And if the tool to repair these double-stranded DNA is broken, then that cell might die. And we use that strategy in management of ovarian cancer because about half of the ovarian cancers are missing the tool to repair when there's a double-stranded DNA breaks. And an example of that tool would be homologous recombination. And those ovarian cancers that are missing those tools, we call them homologous recombination deficient. And BRCA1 or 2 associated ovarian cancer is an example of HRD tumor. So it'll make sense that if we give a PARP inhibitor to those cancers with HRD or BRCA1 or 2 mutation, then it'll likely lead to tumor cell death. So at this point, even though there are lots of research projects that are going on trying to incorporate PARP inhibitor as a part of the mainstay treatment for ovarian cancer, it's currently used as a maintenance treatment for ovarian cancer in the advanced stage setting. The goal of maintenance treatment, we should remember, is to prevent or delay cancer recurrence and to prevent symptoms from cancer recurrence while maintaining excellent quality of life for patients. which means the treatment should have a goal of causing minimal side effects so that the women who are in remission is able to enjoy their time when they're off systemic chemotherapy. I wanted to make a note about this because sometimes we feel the need to be on a type of treatment, even though it may lead to side effects and worse quality of life. And we should remember that the goal should not be to make the quality of life worse. So who's eligible for PARP inhibitor in Canada at the moment? And I should also note that the eligibility criteria and medications that are available to us in Canada continue to change. So the information here now may be different a month or two from now, but this is the current eligibility information in Canada. So the first group will be those who have newly diagnosed advanced stage ovarian cancer, whether it is stage 3 or 4, once they complete their surgery and platinum-based chemotherapy. And the second group will be those with platinum-sensitive ovarian cancer recurrence, and they also have to have a completion of their platinum-based chemotherapy with or without surgery. And for both of these settings, the person must have a complete or partial response to platinum-based chemotherapy in current practice. There are two types of PARP inhibitors that are available in Canada. One is olaparib, which is provided for women with germline, another word for blood or inherited type of BRCA mutation, or somatic BRCA mutation, which is a tumor-specific BRCA mutation. And we use that for first-line and recurrent setting. Niraparib is offered to women with or without BRCA mutation in first-line or recurrent setting. And even though the combination treatment with olaparib with bevacizumab is something that's used in the States and Europe, it is not yet used in Canada. And I should also note that you all may know, but all newly diagnosed advanced ovarian cancer that are non-mucinous type, so examples will be high-grade serous or endometrioid type, should have their tumor and their blood tested for BRCA, because it'll change our counseling on how the PARP inhibitor will work for them, how beneficial it'll be for them, and the type of PARP inhibitor that they'll be able to receive. So in terms of duration of treatment with PARP inhibitor, the recommendation is given based on the trial result. So in the first line setting, olaparib may be used up to 2 years, but can be continued if there's evidence of partial response. And typically a person may be treated until there's evidence of disease progression. For niraparib, based on the trial regimen, it will likely be used for 3 years or until there's a disease progression. In the recurrent setting, based on the trial result, again, it will be used until there is unacceptable toxicity or disease progression. So how much of a benefit can one expect from PARP inhibitor? I think would be an important question that one would ask if their oncologists offer them with PARP inhibitor after completion of their platinum-based chemotherapy. So in the first line setting, in terms of olaparib, the trial that showed evidence for olaparib only included BRCA mutation carriers, and the trial's name was SOLO-1. And based on this trial, where women with advanced ovarian cancer who had BRCA mutation were offered olaparib versus sugar pill, the time until disease progression or their first recurrence was 56 months for those who had olaparib versus 13.8 months for those who had a sugar pill. So the difference was quite significant at 42.2 months. So that was over 3 years of a difference until the time of first recurrence. And in other words, this would be in other words, the risk of death or progression was 67% lower with olaparib. And the overall survival data, the data on how long did they overall live, the data is still not mature. So we're waiting for the final data. In the first-line setting for niraparib, we get the data from the trial called PRIMA. The numbers that you will see here will look different from what you just saw from SOLO 1 trial because they pre-selected patients who are ultra high risk in terms of the high-grade serous cancer. So they chose women who had residual disease after surgery or those who had stage 4 disease. And in this trial, they included all women regardless of their BRCA mutation status. So here, for all comers, the time until disease progression had about 5.6 months of a difference, whether they were on niraparib versus sugar pill or placebo. And in this trial, when they divided patients into their BRCA mutation status, those who had BRCA mutation had 11.2 months benefit by being on niraparib. And when they looked at patients who had that HRD status, the ones who are missing that tool to repair the DNA damage, their outcome was quite similar to the BRCA mutation carrier, which makes sense because these HRD tumor carriers, even though they don't have BRCA mutation, they probably have other types of gene changes that result in HRD. So their outcome was 11.5 months of a benefit on niraparib. And in this trial, when they looked at women who did not have BRCA mutation and who did not have HRD, the benefit that they saw from being on niraparib was 2.7 months, which is the shortest. And I should note that the HRD testing of the tumor is not yet widely available in Canada. So that's the reason why niraparib is offered to women regardless of their HRD or BRCA status. And there will be some trials and a hospital or cancer center specific HRD testing that will become available in the near future. In the recurrent setting for olaparib, we get the data from a trial called SOLO 2. So very similar to SOLO 1, they only included women who had BRCA mutation. And in this trial, the difference in time until their next progression was 13.6 months with olaparib. And this trial has been available for a longer period, so they do have an overall survival data. And what they found was for BRCA mutation carriers who had a recurrent ovarian cancer, being on olaparib improved their overall survival by about a year. For niraparib, the data comes from a trial called NOVA trial. And this trial included all comers regardless of their BRCA status. In this trial, time until their next progression or recurrence was such as this. So for BRCA mutation carriers, there was a 15.5 months benefit by being on niraparib. For those without BRCA mutation, there was approximately 5.4 months of a delay in their disease recurrence. So based on this trial, the niraparib became available to those with or without BRCA mutation. Very recently, there was information that was released by the manufacturer of niraparib, as there was some updated information on overall survival data. This is not yet published in a journal. So based on some of the newer findings, they found that there was actually no difference in overall survival in BRCA mutation group. So even though niraparib was resulted in delay in the disease recurrence, overall length of the life that a woman had on niraparib was not different when it was compared to those who were on placebo. And there was some trend for possibly a worse survival in non-BRCA mutation carriers. And because there was a trend, so trend meaning it was not statistically very distinct difference in survival, but there was some trend. So they're looking at this data very cautiously, and more information is expected in the future. And because of this, you may have some of the oncologists, including this as part of the counseling when someone is, offered niraparib, and in the end, the decision to start niraparib versus not, or stopping in the middle, may be made after the oncologist has a discussion with the patient. So, so some of the adverse events and side effects that are expected from PARP inhibitors, these are some things that we saw from the trial and also from our daily practice. So some nausea, change in bowel pattern is expected, but it is fairly well managed with counseling and medication use. Fatigue is quite common. And some blood test results. So hemoglobin, white counts, and platelets may go down, and that's why we do quite close blood work follow-ups. And with the use of niraparib, high blood pressure or palpitations can occur. And there's a small chance of about 1% of developing acute myeloid leukemia or myeloid dysplastic syndrome from a PARP inhibitor. And as I mentioned, we do monthly blood work, and we do monthly or as needed assessment with the patients on PARP inhibitors. And based on the trials and our clinical experience, most of the side effects are manageable with interrupting the dose for a few days or modifying the dose. And the quality of life was maintained in all of the trials. And we also find that patients actually tolerate the medication very, very well. So these 4 objectives were what we just went through, and I will now move on to Q&A session. And I think we have some patient partners who will talk with us today. I will stop sharing.
Hi, okay, I'm Patty Pitts. Thank you, Dr. Lee, for your presentation. As Stephanie said, I'm the one member of the patient partners who isn't an ovarian cancer patient, but did lose, sadly, a couple of very, very dear friends to the disease. And I was quite involved in their care and support, and saw the side effects that they endured through their regular chemo treatments and other drug treatments. Neither of them, this was a few years ago, so none of them were eligible, even if PARP inhibitors were available back then. I'm not sure that they were. You mentioned that the main aim, of course, is to improve people's quality of life and extend their life. And you presented, there's a lot of information in your presentation that covered an awful lot of different scenarios, some very encouraging, others less so. But overall, can you tell us a bit more about your experience and with managing the side effects? You said that most of them are well managed, and that for the most part, people maintained a pretty high quality of life. But can you maybe expand upon that a little bit, of some of the side effects that people taking PARP inhibitors might be expected to encounter?
Yeah, I think that there are like different categories of side effects that we notice and we counsel them about. So based on the trial results, we do know that there will be some GI side effects. So I think the most important part was counseling patients prior to them starting the medication. So at our center, we give patients different options for anti-nausea medications available with them. And I usually advise my patients to take their medication, especially the niraparib, which is once a day, in the evening with some gravel, if they wanted to try with gravel, because I find that like it really helps them not experiencing any nausea if they take it with some gravel in the evening. And I think that kind of knowing that this could happen is also a very helpful tool, because without proper counseling, some of the side effects can come as a surprise for patients. So I find the nausea is quite well managed with some medications. And palpitations and high blood pressure, we ask patients to monitor their blood pressure quite closely weekly for the first 2 months, and I've had to start some patients on blood pressure medications, and with that I never had to discontinue anyone because of blood pressure issues, because I find that it's quite well manageable. And with the low platelets and hemoglobin, the reason why it can be difficult in the beginning is because they just finished their chemotherapy. So they're still recovering from their treatment. So it does require some time until their bone marrow and their self are both fully recovered from chemotherapy. So in those scenarios, we may reduce the dose of a drug in the beginning, and we may gradually increase as their tolerance improves, or we may do alternating doses of low dose and a higher dose. And eventually we will try to go up to a moderate dose for our patients. So I think those are some of the strategies that I use with my patients, and I find that most of my patients are tolerating it quite well at the moment.
Oh, that's excellent. Thank you very much for sharing that. There's, I'm not sure if I can do this, but I'm just going to pop over into one of the comments in case you haven't said it. Said, one of the participants said, very curious why placebo was offered in this case. Is it the stage of the trial? Seems that a lot of women's survival was put at risk. I don't, can you respond to that? Just you don't have time to get to it later on.
Yeah, I'm not sure which trial. Yeah, I don't know when that question popped up.
Oh,
I can tell you that with all the trials that I discussed, placebo was used, and after and the placebo was used because whenever we do a clinical trial to determine whether a new drug is effective, we either compare it to the standard treatment. And at that stage, the standard treatment for maintenance treatment was not being on anything. That's why a sugar pill, which is a placebo versus maintenance pill, was looked at. And in other, clinical scenarios, if we're comparing adding PARP inhibitor to certain medication is beneficial or not, then in that scenario, the patient will be receiving the standard treatment plus placebo versus standard treatment plus PARP inhibitor.
Okay, and actually my mistake, I think I was reading something was one of the previous presentations, so my mistake, but
no worries.
That was interesting to know and learn. Okay, over to you, Peggy.
Actually, an excellent lead-in, because I actually was on a clinical trial for a PARP inhibitor, and that was my first experience with a PARP medication. So I was diagnosed with high-grade serous ovarian cancer, stage 3C, in January of 2014. So I am now 8.5 years into this journey. And so 8 years ago, at the end of my treatment, I was offered the opportunity to be part of the SOLO-1 trial for olaparib, which is now trade name Lynparza. So I just briefly, like the experience of being on a clinical trial, I jumped on it because I think that we need to move science forward. I jumped on it because I believe that if I didn't get benefits, somebody else would. But probably 95% of my reason was that I saw my oncologist every month. I had greater testing and follow-up and so on. So the clinical trial I was on was a double blind. I was offered either the medication or the placebo. It randomized. I didn't know which I was on. And at that time, there was no standard of care. So it was either you got the medication or the placebo. And I was on the clinical trial for the full 2 years. One of the hardest days of my cancer life was when they said I had to stop, even though I thought I was on the placebo. So my question is, and you covered it a bit in your presentation, but honestly, I got distracted by the chat. So
I'm trying not to look at the chat right now.
Right?
I don't want to
So,
miss any question.
Exactly. Well, so I put the chat away and I figured somebody else will point out if we have a question later that we have to. But anyway, so my question is, why did I have to stop taking that PARP inhibitor after 2 years when I was still no evidence of disease? I know it was part of a clinical trial, but I think you said that with olaparib, you still come off after 2 years.
So I
So
think Dr. Drew and Dr. Tinker are on the line too, and they may be able to add. I believe the Solo 1 and Solo 2 like regimen also came from other trials that used it. And I wondered also another reason, maybe, you know, if you know, whether there is a continuous benefit even though you're not on the PARP at that point. And, you know, if there's a small risk of an AML, like is the risk for AML, MDS, like that risk, does it trump the potential benefit that women will continue to have from PARP inhibitor? However, the recent, I think the recent update from the Solo did show that the risk of AML and MDS does not increase, even though, like, even at like 4 or 5 years.
yeah, but did you say the risk for that was only 1%?
Right.
And my risk of recurrence is way greater than 1%. So that doesn't equate to me. You know, the fact that I have to come off because the risk of MDS, or sorry, and whatever those things were, AML, is if that risk is 1% and my risk of recurrence is extremely elevated over 1%, that makes no sense to me that that's the reason that I would have to stop.
Yeah, I want to hear from Dr. Tinker and Dr. Drew, because I do get asked the question a lot, and I have a few patients on olaparib who's like kind of dreading that 2-year mark. But at that point, I'm planning to talk to them and then make a decision together. Because it is true, like in the first line setting, that's kind of the best time for us to have a control of the disease.
And I know my case was a trial, but like I know that now it's approved. So what's the answer?
Hi, Peggy. Perhaps I can add to that. So I think the main thing is when we design trials, we have to decide what the trial is going to be. And obviously at the time that Solo 1 was designed, nobody knew how long to give a PARP inhibitor for to women who potentially were going to be cured of their cancer. And the trial could have looked at 6 months, it could have looked at 12 months, it could have looked at 2 years. And like Prima, it could have looked at 3 years. So actually the answer is we didn't know how many years to give these drugs for. So like in breast cancer, where you have, you know, tamoxifen for a certain number of years, it's a similar thing. We didn't know how many years to do. So most women in Solo 1 didn't have what's called measurable disease. So you couldn't measure their response to treatment. So after 2 years, most women came off the drug because they'd completed the 24 months. And what's encouraging, if you look at the 5-year follow-up data for Solo 1, is that the majority of those women are still in response, even though they've had 3 years off drug. So that is encouraging. And you could argue that maybe 1 year is enough to take these drugs. And the AML, the acute myeloid leukemia risk, obviously at the time wasn't known. And so it could have been like 20% or 30%, and then you might be killing people of something else by curing another cancer. So obviously we have to be cautious. And I recommend most of my patients do stop at 2 years because of the risk of potential side effects and effects on quality of life. And there is data now, a 5-year follow-up for Solo 1 showing that a lot of women still are benefiting even though they've stopped treatment. But I think if you've got disease that can be measured, you know, on scans, then it is reasonable to think about continuing, but you'd have to discuss that, you know, with your own oncologist, what's the pros and cons of taking these drugs. And we don't know that having them indefinitely is the right thing to do, you know, in women who are in the first line setting, which is slightly different if you've kind of the cancer's come back. So I hope that makes a bit of sense.
It does. It does. And as a follow-up question, and I hope I see all these big brains on screen and I'm just going to capture them. As a follow-up question, I remained no evidence of disease for just about 2 years following coming off the trial. So 4 years to the day from my cancer diagnosis, I remained cancer-free, but 4 years to the day I received the diagnosis of recurrence. So believe me, I'm not complaining. I got 4 years and I've lived another 4.5 since then, right? So like, it's all good news, but I want it to be better. So I experienced a recurrence after stopping the PARP inhibitor. And I chose to go back into chemotherapy because I knew that olaparib had been approved because of the SOLO2 trial for a woman after recurrence if she responded to platinum-based therapy. So I chose that simply so I could get back on the olaparib. And I had to fight and to advocate for it. I had a really great team working on my behalf. And that did happen. So I was on the olaparib, had a recurrence about, I don't know, 18 months afterwards. Had radiation for the recurrence, went back on the Lynparza, and then had radiation again. So I'm now considered, I think, resistant to the PARP inhibitor. If I, you know, am in treatment currently, if I'm no evidence of disease after this, can I go back on olaparib? Can I go on to a different PARP inhibitor? Like for a woman who's been on a PARP inhibitor and has a recurrence, what are their options after that?
So I
There's
think
lots
that's
of us out there.
Yeah, and I think we'll be seeing more and more of women with similar situation. So for those who have a recurrence after being on PARP inhibitor, then that disease would be considered resistant to PARP inhibitor. And
After the first time on a PARP?
So no, like after someone is like, while somebody's on PARP inhibitor or soon after stopping PARP inhibitor, if they have a recurrence, then it would be considered resistant to PARP inhibitor. And we would think that, you know, they have developed different mutations that all of a sudden is making their BRCA functional, or perhaps they've developed a mechanism to, you know, kick out the medication from your cells so they are not functional anymore. So the consensus now is, you know, giving a PARP inhibitor again alone may not be a wise idea because it will unlikely work. The avenues that researchers are looking at right now for those who have a recurrence after trying a PARP inhibitor would be utilizing PARP inhibitor with other medications. So for example, women, there are trials that are going on, and what they would try to look would be combining PARP inhibitor with immunotherapy with or without bevacizumab, because there's an idea that, you know, if, you know, because ovarian cancer so at the moment, evidence shows that using immunotherapy alone for ovarian cancer has not been very promising. But if we combine PARP inhibitor with immunotherapy, it may actually have some synergistic effect. And I think Dr. Drew was actually the author for the study called Mediola that used combination of PARP inhibitor with immunotherapy with VEGF inhibitor such as bevacizumab, and it showed that you know, regardless of their HRD status, there was some benefit. So I think the strategy for those who recurred after PARP inhibitor will be using a combination of PARP inhibitor with immunotherapy with or without VEGF. And also other options that are available, although it's still a clinical trial setting, is there's a trial that's going on right now in several centers in Canada, including like Calgary, Edmonton, and Toronto, where a drug called antibody drug conjugate is used for patients with platinum-resistant ovarian cancer, because there was a single-arm trial that showed that for certain types of recurrent high-grade serous ovarian cancer, if we use antibody-drug conjugate, again, it is a targeted treatment, there was a response rate as high as 30% or so. So there is a trial going on, and there will be a trial that's opening in the near future too, where chemotherapy with immunotherapy is used in comparison to single agent chemotherapy. So those are kind of trials that are actively happening. So, in the future, it may become a standard of care if we do see some good evidence. And also, I think someone talked about this earlier on the chat, but we still use the traditional single agent chemotherapy to people who have, fairly good kind of a quality of life, whether, how, depending on how symptomatic and how ill they are, we still do use single agent chemotherapy, which, does work for some women.
It's working for me right now. So,
Yeah.
Right. I'm back on chemo with bevacizumab, and I'm responding. It's just, this is going to end. And I'm always looking to see,
Yeah.
sometimes you just need to do something.
Yeah.
So anyway, so thank you, ladies, everybody, for answering my questions. Over to you, Patty.
Yeah, thanks, Peggy. And I'm keeping just a wee eye on the chat room, and this one actually is dealing with the THAR session, Dr. Lee. Someone wants to know if you could repeat the name of the anti-nausea drug that you mentioned recommending to women who have that kind of side effect during their treatment.
So at our cancer center, for those who are on PARP inhibitor, we provide them with ondansetron or a Zofran, so that they can have it in the pocket, and then metoclopramide or Maxaran as another option. And then over-the-counter gravel. Some of my patients actually love taking Nirapar with gravel, and then they go to bed. It's so that's something that some people use. And I always check them, like, are you still using the gravel? And then some of my patients said, I actually have zero nausea, so they just have it available just in case.
Great, thank you. And I just have one further question. The Ovarian Cancer Canada is really dedicated to believing that everybody should have access to the best treatment for their disease, no matter where they live in Canada. And as we know, that sometimes can be difficult. And so can you just sort of tell us what the situation is across the country for people wanting access to PARP inhibitors?
So my understanding is across Canada, but I think we did have a chat in the past that PEI may not have PARP inhibitor readily available, but in most areas in Canada, PARP inhibitor will be available to those women that I described in the presentation.
Great.
It will be offered.
Okay, well, thank you so much, Dr. Lee. Now, I guess we go over to you, Stephanie. Oops.
Muted, sorry. I'm going to jump in because the question and answer box here is on fire. So we have a lot of questions. We have about 7 minutes left, so we're going to get through as many of those as we can. So here's a question. My oncologist took me off niraparib last week as disease has returned. She advised that it's only showing to be effective on first-time disease patients, not for those who've had a recurrence. Can you comment on that?
So I think that likely occurred based on the recent release from GSK that showed that there may be some worse overall survival outcome for those who were on niraparib. I'm not sure why, if they were actually had a good tolerance. I haven't stopped anybody based on that letter. So I think that this is something that you will see a huge variation across the country. And I think that we're still waiting for more data to come out. I think Dr. Tinker and Dr. Drew both would like to comment. My plan moving forward is to share the limited information that we have available, and depending on the patient's, like how they're doing and what their disease status is like, I will continue to discuss the pros and cons of being on niraparib for those who are not, BRCA mutation carriers and who are in the recurrent setting. So I will let Dr. Tinker and Dr. Drew kind of give some comments.
Do you want me to go first? Yeah, I mean, I think for women who are having niraparib in the recurrent setting, so the cancer has come back, you had a round of chemo and then you're on the niraparib. So we're not talking about people who've had it after first line. Then you're generally on the drug until it stops working or you can't tolerate it. So there's no limit to how long you're on it for. And that should be still the main thrust of treatment. So if women are on niraparib and they are benefiting, so based on scans showing response, based on the CA125 being in response and being in tolerance of the treatment, then I do not think it's the right decision to take people off niraparib based on this new data that's come out from GSK. And that is because on an individual patient level, the benefit is the benefit that you're actually getting, not the averages from trials. And I think this new information from GSK, it's very important that we have new information. So we don't want to hide new information. And it's important that we disseminate this to our patients and it's disseminated to us as the oncologist, but then you have to interpret the information. So this new information is showing that the survival of women in that trial was slightly longer in those that got the placebo over those that got the niraparib. What we don't know is how many women in the trial came off placebo and went on to a PARP inhibitor. And what we don't know is what subsequent treatments those women had. Some of those women might have had better access to clinical trials and went into more clinical trials than those other women in the other arm. So overall survival is a difficult thing to show a benefit to in treatments where there will be lots more treatments coming afterwards, because those treatments coming afterwards affect your overall survival. So I think there is still maintained a benefit to niraparib, and women should still be on it if they're benefiting from it. But that decision really should be an individual oncologist and patient decision. And I don't think on this sort of kind of forum, we would be recommending individual sort of patients do something, but you should talk to your own oncologist. But I wouldn't be stopping. I agree entirely with Dr. Lee about I wouldn't be stopping women on niraparib because of this new data.
Yeah, thank you both. Dr. Tinker, did you want to weigh in?
Well, I'll just say I agree with that, and I've already started having some conversations with patients in this setting, it's really about sharing the information and deciding on an individual basis. But back to the question that was posed, I think what might have been said is it sounds like that in that particular case, somebody was on niraparib but then had progression, and in that case, I think that would mean that the treatment, the PARP inhibitor, is no longer effective for that patient. And I would agree, although I don't know exactly the wording used by your oncologist, I would agree that right now, if you have progression on a PARP inhibitor, we don't really have any good evidence that going back on a PARP inhibitor, even a different PARP inhibitor, will have any benefit. And in fact, we really do think that olaparib, niraparib, rucaparib, there's a whole bunch of different PARP inhibitors in the world. We kind of, for now, think of them all as the same. They have a class effect. And if you've been on one, there's no known benefit to switching to another one. They're viewed to be equivalent. So if you've progressed on a PARP inhibitor, I think is probably not ever going to be a treatment you would go back on again. Peggy, you told us about your situation where you hadn't progressed, you stopped the 2 years. And it's a really interesting question about what will be the benefit for women who finish the treatment, years later have a recurrence. How much benefit will they have if we treat them with a PARP inhibitor? Again, that's actually a topic of some research we want to do and something we're proposing as a research study. But it's a really important question because there will be many women like you who complete their treatment course, will stay well for a period of time. And if the cancer comes back, do we give them a PARP inhibitor again or not? We need to know the answer. Yeah.
Thank you, Dr. Tinker. I have a couple, well, I have lots more questions, but I'm going to get to as many as I can here. There's a couple here with the same theme. I had to have my dose lowered several times down to 200 milligrams per day from the initial 600 milligrams per day. What kind of effect will that have on efficacy in the long term? Well, up to a 2-year horizon anyway, with the lower dose.
So that is a very good question. In the Solo 1 and 2 trial, they did have patients who had some dose reductions. My understanding is it's always a balance of keeping the medication on so that the patient can tolerate versus losing the efficacy. So the goal that we have is to try to increase the dose back again to higher than I think what did you say 100 milligram twice a day or 200 milligram twice a day, but I think it is a balance. I think that if I have a patient who's BRCA1 or 2 mutation carrier, and then if this is a frontline setting, I think that I will be trying my best to work with my patient to keep them on, even if it is a low dose, because I think that the benefit that we saw from Solo 1 is significant, and given that in the future I may not be able to put them back on PARP inhibitor, because after they have a recurrence and their bone marrow is affected by the chemo again, I don't think that the tolerance will be better. Like, now is the best time to try. So I think that the person will be having a conversation continuously with their oncologist to decide, but I think being on a dose of PARP will be better than nothing.
I think it's important as well, when we develop these drugs, we just kept increasing the dose to being able to tolerate them. So that's how drugs are developed. And we know that all PARP inhibitors are probably dosed too high, and most women need to have the dose, I don't call it dose reduction anymore, I call it dose corrected. So if you are on too much drug, then you're getting too many side effects and your bloods aren't okay, then you're on too much drug, and we need to correct the dose. So we know there's data from the NOVA trial showing that whatever dose of niraparib you're on, it works. And it's because we make up these doses based on the early trials, and we just dose people 300, 200 or 100. But every patient is different in terms of their biology and their size. So for a lot of people, it's too high a dose. So I know patients, I know you get worried when we want to change the dose, but it's usually we're still giving you what's called therapeutic, so effective doses, and we would never go lower than what has been shown to be effective. And I think probably 2/3 of women need the dose reducing, and that's very common. So I started to call it dose correction now. I feel that that's a easier thing to discuss.
Yeah, and I'll note that based on the for the trial that used the niraparib, they started at a maximum dose of 300 milligram for everybody, and then they did notice that women had difficulty with tolerating. So then they actually made a different criteria. So people with lower body weight and low starting platelets, we would generally start them at a lower dose. And based on the trial, it did show the same efficacy. So I agree with Dr. Drew that it is a dose correction.
And I've just seen in the chat somebody said dose tailoring might be an even better term. So I think we've all learned something tonight.
Very nice. Thank you both for that. We have time for one more question for this session, but I just want to let everybody know that obviously this is a very popular topic, so we will revisit it at another time and be able to have another session on PARPs. But for now, we do have time for one more. If ever bevacizumab is approved in Canada and a patient is already on olaparib, do you think it will be beneficial or even possible for one's doctor to add it to the olaparib treatment, even 1+ years onto the PARP treatment?
That is a very good question. So bevacizumab, as you may know, is already approved to be used in settings of advanced stage of ovarian cancer in the first line setting and in the recurrent setting, whether it is mostly for platinum resistant setting. But given that we don't have a data of adding olaparib after, adding bevacizumab after being on olaparib alone for a year, I do not think that it'll be something that's offered, because we create standard of treatment based on clinical trials. So we will need a trial that used that exact regimen in order for us to actually use the combination of bevacizumab and olaparib in the future. So I think what may change in the future may be, like continuing with bevacizumab and olaparib as soon as they're like in the first, like in the frontline setting after initial chemotherapy. But I don't think that we will be adding bevacizumab after somebody is on maintenance for a few years if there is no evidence of disease progression.
Anything to add, Dr. Drew or Dr. Tinker? Okay.
No, I agree with Dr. Lee. I think we have to follow the data and what the evidence shows. I think and that's important.
Okay, I want to thank you all for participating in this session. Dr. Lee, thank you again for helping us to understand some difficult subjects in your presentation at the beginning. Dr. Tinker and Dr. Drew, thank you also for jumping in to answer the ton of questions we had. Peggy and Patty, for your insights and your experiences and for sharing with us this evening. Thank you. As I mentioned, this is obviously a very popular topic, so don't worry, we will revisit it at a session in the future.